All right, this is part 4 in my series on basically the Mycobacterium. In the last 3, I pretty much focused on Mycobacterium tuberculosis, and now it's time for the other ones to take center stage. These are the Mycobacterium other than tuberculosis, or the moths. I'm going to spend a considerable portion of this video on Mleprae, and then just kind of glance on these 3 with a little bit more emphasis on MAC than the other 2. Okay, so I already kind of discussed this in a previous video, but when we think about Mycobacterium and the classification, we largely look at Runyons Classification. Runyon basically asks 2 questions. How long does it take to grow in culture, and what does it look like? So what that first tells you is that Mleprae cannot be classified by the Runyons Classification. Why? Because it can't be grown in culture. So since we're unable to grow Mleprae in culture, it obviously cannot be considered as part of the Runyons Classification. M. tuberculosis is obviously not a moth because it is tuberculosis. If it's tuberculosis, then it's got to be either M. tuberculosis sensu stricto, or it's got to be one of the other ones that is commonly associated with it. If it's not TB, then we look at NTMs or the moths. Okay, so these are going to be broken down into, are they slow growers or fast growers, and are they pigmented or not pigmented? And there's kind of 4 groups that go along with that. Before we get into all of that, I'm going to start with Mleprae. Mleprae is literally the stuff of biblical nightmares. Basically, we're talking about leprosy. It's also sometimes referred to as Hansen's disease. The things you need to know about Mleprae: 1, it thrives in really cool temperatures, which is important to note because it explains the predilection of Mleprae for extremities. So your step 1 book will refer to this as the glove and stocking presentation. So basically the areas of your body that you would normally cover with gloves and stockings. You can also have like a loss of sensation as it infects the skin, and superficial nerves in the area that would be covered by, you guessed it, gloves and stockings become compromised. People often think of this one as something that happened before that doesn't happen anymore. It still does. This one is still available, and it hangs out with our friend the armadillo. The main reservoir for it these days is the armadillo. In fact, in the southeast, armadillos have Mleprae, and roadkill workers actually wind up catching it when they go to clean up some armadillos that were having a really bad day. I didn't mention it on the last slide, but really the only way you're diagnosing this one is microscopically, because remember, we can't grow it. So you have to either look for it microscopically. It will actually grow on a mouse's foot pad if you want to do like a xenodiagnosis. That's the other way, but microscopic is kind of your best bet. Okay, let's talk about the clinical diseases with leprosy. Leprosy is actually fascinating, and it's an immune response because we see completely different diseases based on the immune response that's made. So both tuberculoid leprosy and lepromatous leprosy are caused by M. leprae. It's the same organism. It's entirely how you respond to it that matters. So patients with tuberculoid leprosy make a strong Th1 response with good cell-mediated immunity. Basically, they put up one heck of a fight. And when that happens, they wind up with a lesser disease. So you get this erythematous hypopigmented plaques with these raised, well-defined borders. You get infiltrate of lymphocytes around the center of the epithelial cells, but you also control the infection very quickly. So there's very low infectivity. So it's very well controlled, and it's all due to this strong Th1 response, and that is called tuberculoid leprosy. In lepromatous leprosy, we kind of see what happens when the body can't fight the infection appropriately. This is Th2 IgG mediated. It's a Th2 response, and it actually promotes kind of a humoral response, and you have a weak or non-existent Th1 response, which means it's not going to get contained behind that wall of macrophages. So this is kind of what people think of when they think of leprosy. There's high human-to-human transmission, but the exact mode isn't really known. It might be aerosol. Basically, the symptoms are that you get lesions starting at kind of the distal parts of the body with the cooler temperatures. You're going to get a bilateral neuropathy with glove and stocking pattern. You get these poorly demarcated raised lesions all over the body, but most notably on the extensor surfaces. And there's large amounts of bacteria in the leprae. You can also see profound facial deformity, which is known as Leonidas facies. So this is basically you get collapsing nose, thickening of the skin. So it's just a completely different disease as the patient makes a completely different response. So we talk about them as if they're completely different diseases, but really it's all on the ratio of Th1 to Th2 responses. Treatment is also kind of scaled appropriately. So for tuberculoid, you're only going to treat for about 6 months with dapsone and rifampin. For lepromatous, it's dapsone, rifampin, clofazimine, and you're going to be taking that for years because basically we can't trust your immune response to make up for it. Okay, so now what about these guys? We're going to follow the Runyons classification to go through all of these. So when we are thinking of the different ones, if we go back to our acid-fast stain, if it was not, then that means one of two things. It's not Mycobacterium, or you had an insufficient sample and you might need to retest. If it was acid-fast, but only partial, it's not Mycobacterium. What is it? It's likely Nocardia. That's the other one that we think of when we think about acid-fast. If it is, then it might be complete and you might have Mycobacterium. If you went culture, you could look at how fast it grows. Does it grow quickly? Then it's one of these, M. fortuitum, colinae, or abscessus. If it grows slowly, it's either not TB or it's TB. If it's not TB, then we go into what color does it make? Is it a photochromogen, a scotochromogen, or a non-chromogen? And this is kind of the scaffold that we use to explain the MOTS. So let's talk about them based on the color that they get. So group 1 are your photochromogens, okay? These are slow growers that produce pigment when exposed to light. So if you look over here, this is M. marinum, and you can see that when it's exposed to light, it becomes this brilliant yellow color. While it's in the incubator, it might be clear because there's no light, so it's dark and it might be clear to weak colored. But when it's exposed to light, it gets this brilliant yellow color. Group 2, they are colorful all the time. So whether they're in the incubator or out, they're going to have these brilliant colors. Group 3, non-chromogens. They're never going to produce beautiful colors no matter what you say. Group 4, these guys, we don't really worry about their colors because they grow out really quickly. You're not very likely to hear about these very much. They're sometimes associated with cellulitis infections, and they can get in the lung, but these are really just more skin infections. Okay, so M. marinarum. M. marinarum, typically found in water, as the name would suggest. We typically associate these with fish tank granulomas. Patients get them literally cleaning out their fish tanks. You can see a pattern that's similar to sporotrichosis, which kind of looks like a marching band of spots up the arm or leg where the infection started. So this is an example of a patient with M. marinarum as it's moving its way up on a patient. Okay, Emkin. Emkin, this is a cause of pulmonary disease. It's similar to pulmonary TB, but it can also be non-pathogenic. So you need to use specific criteria, which are listed here to determine if it's actually a pathogen or not. I'm not going to go through these, but this is kind of more an FYI slide. MAC. I expect you to know MAC. This is a non-chromogen, and we see this in both healthy and immunosuppressed individuals. Most common presentations are one of two people: middle-aged to older Caucasian men who are heavy smokers, or middle-aged elderly females. This is often sometimes known as Lady Windermere's syndrome. Lady Windermere is actually an Oscar Wilde play called Lady Windermere's Fan. Lady Windermere suspects her husband is having some affair, so she seeks one out herself, only to find out that he wasn't having an affair. The woman he was spending time with was her mother. Very torrid and confusing of Oscar Wilde himself. And so is Mac. Mac is very confusing. So when we think about Lady Windermere, I want you to think of librarians. Thin, elderly, very proper women who have this frail presentation with a chronic cough. And they kind of, it's like a stifled cough, like, excuse me, like that kind of, always clutching a handkerchief and just, and that's kind of what we expect to see. We also see significant bronchiectasis on the chest x-ray, and that's kind of your big thing. So if you have a patient of that age with kind of that suppressed cough that has significant bronchiectasis, you might consider MAC instead of MTB. You can see disseminated disease with MAC, and it actually winds up being a really big problem for patients with advanced HIV disease. In children, you're more likely to see scrofula, so that's cervical lymphadenitis, which I showed you in a previous video. Okay, M. fortuitum colanae complex. This is a rapid grower. They cause pulmonary and skin soft tissue disease. The biggest thing about them is that they don't actually respond to the typical anti-TB drugs, so they're actually very difficult to teach. In the moths, the organisms I really want you to understand are Mleprae and MAC. If you understand those two, then you've kind of gotten what I wanted you to get out of this video.